Hello people, this is Dr. Muskaan this side, and today I'm going to share a very classical history of COPD. And let's start. Here is 65-year-old male who has came to ER with chief complaints of shortness of breath since 3 days and pain in abdomen since 3 days. On arrival, ABCS was done, airway was patent, there were no signs of airway obstruction such as stridor, dysphagia, dysphonia or choking, or some patient is holding his neck, oh मेरे को सांस नहीं आ रहा, ऐसा कुछ भी नहीं था. On breathing assessment, respiratory rate was 26 per minute, which was showing tachypnea because normal lies between 12 to 18 per minute. SpO2 was 91% on room air. On circulation assessment, pulse rate was 130 per minute, which shows tachycardia because normal lies between 60 to 100 per minute. BP was 140 by 90, sensorium was alert, GCS was 15 by 15, E4, V5, M6. HOPI. Patient was apparently alright 3 days back when he presented with shortness of breath, which increases on exertion. MMRC rate was 5 because he does not go out from home due to shortness of breath, or he feels shortness of breath while bathing, dressing and undressing. Now this was also associated with orthopnea, that was he was also not able to breathe on lying down position, and there was air hunger also, that means it was also associated with paroxysmal nocturnal dyspnea, PND. He also complains of pain in abdomen since 3 days, which was gradual on onset, progressive in nature and associated with constipation and nausea. There was negative history of fever, vomiting and loose stools. Past history: he is known case of bronchial asthma since 7 years, and he was using ethylene in meter dose inhaler since 5 years. He is known case of cardiac disease which was not documented. It might be arrhythmia or CAD since 10 years. There was a history of dust allergy since 10 years. There was negative history of hypertension, type 2 diabetes mellitus, thyroid. There was no history of seasonal variation or diurnal variation. Past surgical history: there was surgery of right leg due to road traffic accident 8 years back. Personal history: he stopped smoking 10 years back. He smokes 1 bundle per day for more than 25 years. He takes alcohol occasionally. He chews tobacco since 25 years occasionally. General examination: decubitus. Patient was lying on bed. He was uncomfortable due to his NIV mass. His GCS was 9 by 15. He was conscious but not actually oriented to time, place and person. Vitals: BP was present vitals. BP was 125 by 60, respiratory rate was 23 per minute, pulse rate was 110 per minute and SpO2 was 98%. Parallel and edema was present. Icterus, clubbing, cyanosis and lymphnopathy was absent. Investigations: when I have seen the chest x-ray of the patient, there were hyperinflated lung fields, bottle-shaped heart, and on percussion there was hyperresonance node also, and it is taking me towards COPD. Why COPD? Because there is a triad in COPD, which is shortness of breath, cough and sputum, and it is a small airway disease. Further investigation of patient: CBC picture shows anemia and leukocytosis. KFT picture shows increased urea, increased creatinine, hyponatremia and increase in uric acid levels. LFT picture shows serum transaminitis because they were raised SGOT and SGPT levels. Serum amylase level were normal, that was 70. Serum lipase level was slightly raised, it was 135. And from now we can say yes, AKI is also there because of urea, creatinine level and uric acid levels are not normal. HBsAg, HIV 1, 2, 1 and 2, HCV all were negative. NT-proBNP was 0.05 nanogram per ml. Ultrasound of whole abdomen shows GB sludge, and echo report shows 15 to 20% of reduced ejection fraction, which takes us towards systolic heart failure. So yeah, this was all about this case. Thank you for listening to this case, and take home message from this case is, whenever you will see the case of COPD, there are this triad which is present in the patient. There is typical X-ray of COPD which will support your diagnosis, and there will be a particular history, personal history of smoking and alcohol. Yeah, that's it. Dr. Muskaan Mansal is signing off now.